All right, let me introduce today's speaker. We're really happy that Dr. Steph Baral is with us today. Dr. Stefan Baral is a professor, excuse me, in the Department of Epidemiology at Johns Hopkins School of Public Health, having completed his training in community medicine as a fellow of the Royal College of Physicians and Surgeons of Canada and family medicine with the Canadian Council of Family Physicians. Dr. Baral, in his role as the co-director of the Program for Implementation and Equity Research in the Center for Public Health and Human Rights, Dr. Baral has focused on trying to understand why people continue to be at risk for acquiring and transmitting HIV, with a focus on the interactions of structural and network-level determinants with individual-level proximal risk for HIV infections. With colleagues, he has focused on advancing measurement and responses to stigma affecting sexual and gender diverse communities in the US and around the world, which is a lot of what we will be hearing about today. I just want to note and welcome Steph and his colleagues that Steph is the founding co-director of the NIMH-funded excuse me, NIMH-funded Center for HIV and Mental Health Stigma Elimination Strategies, known as CHIMES. This aims to support investigators to increase focus and methodological rigor of stigma-related research. So we're pleased to welcome Steph and his colleagues to our group of NIMH-funded ARCs, or AIDS Research Centers, as they're called. And it's just great to have you part of that group. Congratulations on that funding. And I know Steph for many, many years, particularly through my colleague and collaborator, Chris Byra, and others. Steph is a very generous collaborator and just an all-around good guy. So welcome, Steph. I'll turn it over to you.
Thanks very much. Yeah, I'm excited to hear about Dr. Sebelius's talk later. That's wonderful. Busy day for you all. So indeed, I have the opportunity. Oh, sorry, I need to start sharing again. Just share. Okay, and then just to be sure everybody can see this, you can see the slides.
Yep.
Yes.
Good.
Great. Yeah. So I really appreciate the opportunity to come today and to speak to both centers. I will just forewarn, there's a tremendous amount of data in these slides. Happy for them to be shared afterwards for folks who want to follow up. A lot of it has been published, not all of it. And so I just as a forewarning that it's a little bit of a heavy talk. But indeed, the focus is really to look at structural determinants of STIs and HIV among sexual and gender diverse communities. I've not engaged with ever with any for-profit companies and have also no non-financial disclosures. So I want to start by sort of presenting the context in 2024. And I will say I started doing this pre-November, pre-November. So I think that context is obviously evolving and becoming more difficult. But I will present some of the thoughts around context and then some thoughts around, or just some introduction of like the two main studies that we use for a lot of the data that I'll talk about today. So the American Men's Internet Survey, or AMIS, and the Transgender Women's Internet Survey and Testing Platform, or TWIST. And, as it relates to structural determinants, I'm going to sort of focus on, I think, four key kind of themes throughout the talk, which is one, really the importance of measuring specificity by population, specificity of structural determinants, specificity of risks, specificity of needs, optimizing our measurement in this space of structural determinants and of stigma specifically. I'll present some of the data that we've collected, others have, of like the outcomes of structural determinants and how powerful they are in driving individual outcomes. And then some thoughts of promising strategies and policies. And then I think just sort of given what's happening in the world and some concerns around what's happening internationally, I also thought it was useful to at least provide some international context to what's happening, because it's just really quite similar in terms of some of the dynamics across the United States and some of the dynamics internationally. So, I think this crowd understands well that, sexual and gender diverse communities have been consistently and disproportionately affected by HIV and other STIs across the US. So I won't dwell on it. That has been a consistent dynamic since their emergence of HIV and obviously the kind of continued resurgence of STIs over the last many years. But I think importantly, HIV and STI risks within sexual and gender diverse communities are actually extremely heterogeneous. And we often focus our explanations on individual behaviors. And we're going to try to challenge some of that today. And then I think it's important to say that the support for structural interventions, research, and programs, particularly for sexual and gender diverse communities, remains really limited in relation to sort of the rhetoric around the understanding of harms. I was going to talk more about some of the work that different health departments that we've engaged in are doing, but as you know, a lot of it is rhetoric, and it ends up not being as much actual tangible programming and investment as I think we would like to see in relation to the sort of understanding of how important these determinants are. As it relates internationally, but I also think domestically, is that the sort of concept of heterogeneity or disparities is a fundamental principle in infectious disease transmission dynamics. And I think that's important because people often, we sort of tend to homogenize people, whether we mean to or not. And it's particularly important to address the needs of folks who are particularly marginalized, particularly at risk, and as being central to an effective response. And then there's this concept of equity, which I worry is going to be increasingly difficult to talk about, but I think we kind of need to lean into. Because equity is all about addressing conditions that causally increase risks without amplifying or concentrating risks among marginalized communities. And so that is the goal of it. And it's important because well-meaning interventions that don't take equity into account can actually concentrate epidemics and make them ultimately harder to control, just in the empiric sense. Even if you don't share the same moral compass as us, that is just a fact. And so we need these specific and targeted efforts to really address HIV prevention needs of communities that are marginalized, that are at risk. And that is central to an equitable response. It's also central to an effective response. So in terms of AMIS, I just want to introduce again, like the methods as an overview. This is an annual cross-sectional survey that's led by the PRISM team at Emory University. And it started in 2014, and we've been partnering on this with NIH-funded work since 2015. The objective of it it was sort of like an online cousin of the NHBS, the National HIV Behavioral Survey that the CDC has been running. But the idea being to assess trends in HIV risk behaviors, use of testing services, access to prevention services. The eligibility for AMIS was being a cisgender man, being 15 and above, a resident of the United States, and ever having had sex with another man. And the recruitment is mostly it's online. There's some outreach that happens sort of via provision of tags with QR codes and whatnot, but a lot of it is through influencers. And I'll just say, from 2014 to 2020, it was less competition for large-scale online national surveys. I think over the last number of years, it's become harder and harder. And there's also been, I think, as many people may know, more bots and the explosion of bots kind of completing the surveys and the difficulties in doing online work. But nonetheless, the group at Emory has done really well in making sure that the ads remain sexy and fun and that people continue participating in these surveys. And I think they do so much of that work, and it demonstrates in terms of the numbers of folks that continue to participate. But the core survey for AMIS, focuses on demographics, on sexual and substance use behaviors, HIV testing and diagnosis, HIV prevention use with a focus on PrEP, mental health. And then, as noted, there was always some stigma questions, but since about 2015, there's been a real focus on the measurement of stigma and discrimination in the context of AMIS. And then there's been sort of additional rotating or items that some of the participants are randomized to. including the measurement of intersectional stigma, patient portal preferences, MPOX, housing, and justice involvement. And I'll speak to some of those data today, or now, soon. And then TWIST. So this is the Transgender Women's Internet Survey Testing Platform. This is a cross-sectional online survey for transgender women and trans-feminine folks in the US that's been active with a pilot first in 2019 and then since then. The eligibility is being 15 and above, identifying as transgender woman or trans-feminine, being a US resident, and ever reporting oral, anal, vaginal intercourse. Advertisements, again, it's heavily here, particularly with the use of influencers, but general social media, and then prior participants are invited to participate. And I'll say, I think similarly here, the leadership at PRISM has been really innovative in their use of engaging first with influencers, but also in the use of really great ads to continue to support involvement as more and more surveys continue to launch and just online engagement in general. But the core survey includes demographics, similar demographics, sexual and substance use. The big difference, obviously, since its inception was a real focus on access to gender affirmative services and care in general, with focus on hormone therapy and surgery. The additional rotating or randomized items include intersectional stigma, housing, justice involvement, and MPOX again. So, in terms of methods, overall, these are HIPAA compliant surveys. They take place in both English and Spanish. There's a sort of brief introduction eligibility screener. And then, you consent and you immediately start taking the survey, and you really have to complete that survey in a single session. Most people do it on a mobile device, and then there's the optional sign up for sort of future studies via email. And we've had these one-off surveys. We had a one-off MPOX survey. We're doing another one soon. We had a one-off STI survey near the beginning of COVID, just to understand in April of 2020, how folks' access to STI services were being affected, for example. So just to start, I want to start thinking a little bit about the importance of measuring specificity of structural determinants and risks by population. And this is work led by Caitlin Atkins, who's in social behavioral interventions within the Department of International Health at the School of Public Health, and has a real focus on sex work and transactional sex. And so these are data focused specifically on gay and bisexual men and other men, MSM, who report transactional sex. The methods were using AMOS data from 2017 to 2021, and there was a summarizing first the prevalence of transactional sex that was defined as the past year receipt of money or drugs for sex and associated characteristics, and then using a modified Poisson regression to really look at the relationship between past year transactional sex, self-reported STI diagnosis, self-reported HIV status, ART use amongst people living with HIV, and then PrEP use. And I'll say we do have a biomarker component to both AMOS and TWIST, but these data are self-reported data. So obviously there will be some folks who won't be aware of their status, for example, as living with HIV. And then we also look at PrEP use for people who are self-reported not living with HIV. And then here there was also, we want to sort of further that element of specificity by looking at differences by urbanicity and rurality. So across about 50,000 participants from 2017 to 2021, and these, importantly, 50,000 unique participants, the average transactional sex prevalence was about 3.7%. So we saw sort of an increase from 2017 to 2020, and then a decline. And we've seen some rebounding of this in the last year and a half. And so there was just sort of those interruptions, obviously, in sex networks and the ability to sell sex. But nonetheless, overall, about 3.7% amongst these folks. But I think it's really powerful when we look at how some of these structural determinants affect folks reporting transactional sex versus others. And so transactional sex was associated with lower education and income, past year homelessness. So almost 20%, 18% of gay men reporting transactional sex had reported past year homelessness, compared to 3%, which I think is still high amongst folks not reporting transactional sex, but obviously so fundamentally different. And then also, not having health insurance. But we also see kind of clear relationships with kind of sexual health outcomes. And so, men who report transactional sex were more likely to report condoms anal intercourse, but that was particularly the case with serodifferent partners. So they were nearly twice as likely to report condoms anal intercourse with serodifferent partners as compared to gay men not reporting transactional sex. There was a significantly higher levels of illicit drug use, and in addition to that, injecting drug use. And when we looked at HIV outcomes and STI outcomes, we see that, amongst gay men reporting transactional sex, they were more than 2 times likely to report an STI diagnosis, about 40% more likely to report a prevalent HIV infection. We didn't see a clear relationship with PrEP use, but we did see a decrease in ART use, again, among people self-reported living with HIV, about 10% less likely to use ART if living with HIV. But we also, when we sort of think of this idea of specificity, we want to look at urban-rural divide, and that's always been a focus of the folks at Emory, particularly gay men living in rural settings, and I should say sex and gender diverse communities living in rural communities. But we see these relationships be even stronger. So, folks in rural communities who report transactional sex were more than 2.5 times more likely to report an STI, were twice as likely to report living with HIV as compared to other MSM. And so, in the context of, I think, what we know to be very limited services for gay men reporting transactional sex, and in fact, shutdowns on websites that were doing outreach and engagement, we actually see that these, that folks are being disproportionately affected, not just by structural determinants like housing but also like really prevalent, clear, proximal outcomes like actually living with HIV. That same applies to work amongst data amongst transgender women. And so these were data and analyses that were done in partnership with the CDC. And I'll just say, I think, given the limited data, national data that exists amongst transgender women, the CDC really wanted to partner in on some of these analyses. So these were analyses led by Winston Ibarra at the Division of STD Prevention at the CDC, looking at sort of both STI testing and separately among STI diagnoses amongst transgender women. So out of about 3,000 participants in that year, about a third had reported any bacterial STI testing, and the majority of testing was urethral, but also rectal, pharyngeal, and neovaginal to a lesser extent. But when we look at the determinants of STI testing, we do see higher STI testing amongst transgender women reporting condomless anal sex, which I think is ideal, so that folks that might be at higher risk of an STI are reporting more testing. But importantly, we saw gender affirmative services being the most powerful predictor. So, folks who would disclose their gender identity to a healthcare provider were more than 2 times more likely to have had an STI test. Folks who had hormone therapy for either medical transition or gender affirmation were 60% more likely to have tested. And then some other determinants. So folks who are younger were far less likely to have tested for STIs. Folks experiencing severe depression, were far less likely. So, on the PHQ scale, were far less likely to have, reported STI testing. When we look at STI diagnosis, first of all, I think overall it was quite high to us. That 16% of folks who had reported at least one bacterial STI. And so, and it was kind of an even divide between gonorrhea, chlamydia, and to a little bit of a lesser extent, syphilis. But we also see specificity of structural determinants. We saw Black, non-Hispanic transgender women more than 2 times more likely compared to white non-Hispanic transgender women to report an STI diagnosis. We saw Hispanic transgender women more than 50% more likely to report an STI diagnosis. We saw clear STI diagnoses, amongst transgender women living with HIV, strongly so. We saw that as well amongst people reporting condomless anal intercourse and also problem levels of drinking. I think one really powerful piece of data that I want to highlight here is that, amongst transgender women reporting hormone therapy for gender affirmation, they were far less likely to report an STI diagnosis. And I think, you know, in the last slide, I showed you that folks that are engaging and are supportive hormone therapy and gender affirmation were more likely to have been tested, but also less likely to have been diagnosed. So I think just really speaks to the importance of gender affirmation in and of itself being important, but also as creating opportunities to do better with sexual health outcomes like STIs. So a second kind of theme that I want to talk about is this idea of like how we're even measuring, you know, how we're measuring stigma, how we're measuring structural determinants. This is work also led by Kate Atkins. And I think many folks on the call will have been, you know, increasingly familiar with the sort of concept of intersectionality, with that work really advanced by Dr. Bowleg, Chair Willie, and many others. But it really speaks to policies and practices and behaviors that are rooted in overlapping systems of power. And so trying to move away from sort of attribute-specific elements of stigma and more towards trying to understand people as they are. And increasingly, it's really been shown and understood to drive inequities across individuals and communities based on multiply marginalized identities and conditions. And you know, I think there's been less of is like studying it at scale. Even though we believe and sort of conceptually understand it to be a fundamental cause of diseases, obviously including HIV and disparities and other disparities. You know, it hasn't really been studied at scale. And so we had an opportunity to do that in the context of these surveys. This is, you know, the sort of underlying measures that we're using been really developed by Aidan Scheim and Greta Bowers and others in terms of the Intersectional Discrimination Index. And it's really getting at this idea of major intersectional discrimination of like, because of who you are, and that could relate to both skin color and ancestry and religion and gender identity and sexuality and beyond. Have you ever experienced social systems exclusion? Have you been fired or turned down from a job? Have you been evicted or denied housing? Have you been unreasonably stopped or searched? Have you unable to, you know, engage in financial systems in terms of unable to open a bank account? And also violence and harassment. So separately, being harassed at work, threatened with physical and sexual attack, experiencing physical violence, sexual violence, and also theft of property and vandalization of property. And so the analyses here were modified for Poisson regression again to look at prevalence ratios and 95% confidence intervals. And we adjusted here for age, race, and past year condom sex, and also seeing a healthcare provider. So things that we also know to be powerful predictors. We wanted to try to isolate the effects of intersectional stigma in this. Again, overall, in this sample of AMOS, we're including about 4,000 folks who were randomized to getting the intersectional stigma measures. About 90% had seen a healthcare provider, about 60% had received an HIV test, similarly had received a bacterial test, about half had used PrEP, and about 80% report condomless anal sex, and a mean age of about 45. So I think overall, what you can see is about 4%, so 3.9% had this is lifetime exposure to major intersectional discrimination, but about 4% overall had experienced this. But you can already see higher burdens among MSM of color, among MSM living with HIV. And then when you look at, in terms of, move this to the side. When you look at violence and harassment, again, you see that about 14% overall had experienced violence and harassment, so more common than social systems exclusion, but that was particularly affecting MSM living with HIV. And when we look at some of these relationships, again, this is sort of the full sample of folks. As you know, what you can see is just really clear relationships with HIV outcomes. And so importantly, this is comparing you know, gay and bisexual men who had experienced social systems exclusion to gay and bisexual men who had not experienced social systems exclusion. Similarly, for gay and bisexual men who had experienced violence and harassment compared to other folks. And you can see how powerful these predictors are in terms of being more likely to be living with HIV, you know, in terms of having experienced antibacterial STI, basically everything. And even this one chlamydia dynamic was you know, it was sort of a secondary analysis. It was clearly trended to being that. So it just shows that even, again, amongst gay men, that it is folks that have experienced these social systems exclusions and violence and harassment that are being disproportionately affected by these sort of very proximal outcomes of living with HIV and a bacterial STI. When we hone in, particularly among MSM of color, we see these relationships. Again, now this is importantly comparing MSM of color to other MSM of color. So MSM of color experiencing social systems exclusion compared to other MSM of color. And importantly, again, you just see these relationships even more powerfully. So we know gay men of color are disproportionately affected by HIV, but you start seeing the sort of powerful dynamic around structural determinants in terms of driving those disparities. Similarly for bacterial STIs, and some of the samples are lower. It's 1,200. It's still large, but in terms of people experiencing STIs, some of the sample sizes get lower. But we saw these really clear trends and even significant outcomes in many cases. Now, when we look at the same dynamic among transgender women, I'll just say, again, we use the same work that was led by Dr. Scheim and Dr. Bauer, asking these questions around social systems exclusion. However, here, just given how common the experience of social systems exclusion is, about 50% had reported lifetime social systems exclusion. So here, these analyses are all really focused on past year experiences of social systems exclusion. Even from a lifetime perspective, though, I'll just say trans feminine and transgender women of color were far more likely to report ever social systems exclusion. Similarly, that amongst people living with HIV, even more so. But you can also see those dynamics in the context of past year social systems exclusion. And so overall, in the full sample is about 11%, but you can see it less so affecting white women, more so affecting women of color and also women living with HIV. And again, these relationships, I think, were really powerful for us to see in terms of the heterogeneity that existed even amongst, for example, transgender women of color. So overall, transgender women who reported past year exclusion were more likely to report HIV, were far more likely to report a bacterial STI. But when we compare transgender women of color who report social systems exclusion compared to other transgender women, they were nearly 4 times as likely, with obviously wide confidence intervals, but 4 times more likely to report living with HIV. We saw that same relationship amongst with bacterial STIs. And so I think, it just sort of says that, yes, we know that transgender women of color are disproportionately affected. But when you start leaning into it, you can start seeing how powerful, again, these structural determinants are in driving those disparities within and then amongst transgender women of color. So then moving on to some data around the outcomes of structural determinants. I think we are moving into an era where we're going to have to continue proving how important structural determinants are, that I think folks are not going to be convinced about its importance just because. I think we're going to be put in this position where we have to show these relationships. So here we wanted to look at these relationships with homelessness and HIV prevention. This is work led by Amrita Rao, who now has a K from NIMHD to focus more on these dynamics and really to develop and evaluate interventions from this work. But definitions of homelessness here were living on the street or a shelter or in a single occupancy hotel or a car in the past 12 months. Again, it uses a Poisson regression to look at the relationship between homelessness in general and then PrEP among people not living with HIV. And I'll actually talk about ART towards the end of the talk. And we want to try to understand those interactions with race. In these analyses, it included about 4,000 cisgender gay bisexual men, overall about 31 years of age. And so these were folks that were randomized to getting a bit of a longer housing assessment. But overall, in Amos, homelessness was associated with people living in the South, with people with a high school or lesser education, younger, and no health insurance. And importantly, just again, from an overall perspective, folks, Black gay men, people living with HIV, I should say Black gay men living with HIV were more than 4 times more likely to report homelessness as compared to folks who are not Black and not living with HIV. And so overall, you just see these sort of powerful determinants around housing. But amongst people who are not living with HIV, we saw about a 20% decrease in PrEP use in the last 12 months. We similarly saw those dynamics in terms of folks with no health insurance and lower educational attainment. So while we continue to sort of understand and focus on ways of better delivering PrEP, these structural determinants are such powerful limits, ultimately, of all of those programs, just realistically, in terms of reaching folks. I wanted to introduce, it's funny that this slide set doesn't include my MPOX slides. Chris, are you able to, I'm going to have to use till you switch over and you share that most recent presentation I sent you? Or do you want me to just quickly pull it up?
I'm looking for.
Yeah, you know what? I'm going to stop. I'm going to stop sharing for 1 second.
If you give me a slide number.
Hold on, let me just.
It's the one with the US map?
Yeah, hold on, just one. So interesting.
The one maybe titled Model Building for Mpox Vaccination?
Yeah, it's okay. I've got it.
Oh, okay.
Got it. And I'm sorry, I modified these slides so many times that I created different versions of them. So apologies for that. But we'll get right into it. Great. So, I think, I wanted to talk a little bit about Mpox, and as you can see, this is a bit of a late addition. As you can see, this is a little bit of a late addition, but I thought it was important because this work led by Tom Carpino, who's a PhD candidate within our department, a final year PhD candidate, formerly at Columbia. So some of you may know him, formerly at ICAP. But I think, he's been particularly interested in Mpox. And I think one of the things, and has an F31 focus on this work. I think one of the things that we saw with Mpox was just like how quickly the disparities that have existed for so long were recreated in the context of Mpox. And, what you can see here is a heat map, basically, of any vaccination, any Mpox vaccination, going from red all the way to green. And when you look at this map, you could imagine it being a map of, STI services, PrEP services, but in fact, it's about Mpox vaccine uptake. And it just recreated themselves so quickly and so powerfully in the context of this sort of rapidly emerging pandemic. And so Tom has really been focused on this and studying this and wanted to understand the predictors of, basically having had access to Mpox vaccines. And he did that adjusting for age and race, ethnicity, and income and sexual orientation. And really, again, wanted to understand this using a socioeconomic model with sort of individual and community and network level determinants. And again, I wanted to show it because I think, when you look at folks gay men living in a rural area, they were far less likely to have access to Mpox. But importantly, folks who are out to a healthcare provider as gay men were far more likely. And so again, we've always wanted to encourage people to be able, if they can safely be out, to be out. And here you can see these strong relationships in terms of being able to then access both sort of 1 and 2 doses of Mpox. In fact, we saw it even stronger amongst people who ultimately had 2 doses of Mpox. We also saw really powerful network level determinants. And so, we saw if folks were sort of in networks where people were more concerned about getting Mpox, they were more likely to have both sort of 1 and 2 doses. And also if they were in networks with higher awareness of Mpox, again, we saw people both getting Mpox vaccines. But we also see here really powerful structural determinants. And so, food insecurity was associated with less likely to have had Mpox vaccines, again, outside of all these other determinants and adjusted for them. And then, I think we know this, that, folks, because so many of the Mpox vaccine programs were often implemented in the context of STI and PrEP services, we see that folks who have reported access to STI and PrEP were more likely to have accessed Mpox vaccines. But it also then shows how rapidly the disparities that we know to exist within STI testing and PrEP were recreated and even reinforced in the context of Mpox. And so I think it just, it speaks to the importance of as this continues to affect us, and it's obviously not going away, and as there's concerns, obviously international concerns that are very real, but also, domestic concerns are in Clade 1, that we have to think about how we're going to do better outside of our traditional service delivery platforms. And then I wanted to talk a little bit about, finish this part of the talk, really talking about promising strategies to address structural determinants. And, here, this is work led by Dr. Kevin Jackman, who has a KO1 focus from ARC, which is focused on studying patient portal use and as a way of enhancing STI disclosure among historically marginalized gay men, particularly gay men of color. And so here he wanted to study the past use of patient portals to view any test results, to view HIV viral loads, to show a partner STI test results, and to share HIV viral load test results with partners, and then build a Poisson regression model. As you can see at Hopkins, we really love Poisson models. But I think one of the things that surprised us when we did this, and people were randomized to participating in this survey, and so not all AMIS participants got it, so included about 2,600 folks. But was how commonly folks were using patient portals. So about 90% had used the patient portal to look at any test results. About 20% had showed an STI result to a partner. About 80% had viewed of folks living with HIV had viewed their viral loads, and about 23% had showed a viral load to a partner. And so I think it really speaks to the potential reach that patient portals have as a way of delivering programs and delivering services and delivering information, particularly to folks who are more marginalized. And that was the case when Dr. Jackman looked at who was using the patient portals to disclose STI results to partners. He found that it was more common amongst folks that had more STI tests over the last year. But he also really found that it was far more common among Black gay men as compared to white gay men, and also amongst folks who've experienced more stigma from family and friends. And we've seen that in other settings, that folks who are experiencing more stigma rely more on online services as a way of accessing information. So that was, I think, clearly shows the potential of delivering services via these patient portals. And then the sort of final domestic piece I'll talk about is sort of the idea of promising policies. And I think, again, we're entering into a time where we need to protect these policies, and we need to show how powerful they are. And so the one that I'll talk about today is HOPWA. Many folks here will be familiar with it, but it's the Housing Opportunities for Persons with AIDS, not my language, program. It's operated by HUD, the Housing and Urban Development, and it's really the only federal program that exists to focus on housing needs of people living with HIV and their families. And here the goal was to build a multi-level mixed effects regression model to look at homelessness and current ART use among people living with HIV, and adjusting it for age, race, education, recruitment year, substance use, and also state level Ryan White Part B funding. And then to stratify those results by HOPWA funding per person living with HIV. So taking the overall HOPWA funding and dividing it by the numbers of people living with HIV in each state. Now, importantly, homelessness in general decreases the likelihood of current ART use by about a half among people living with HIV. So it is incredibly powerful in all of our studies, consistently been an incredibly powerful determinant of ART use among gay and bisexual men living with HIV. But what we see here is that among states who received at or below the median level of HOPWA funding per person, you see that relationship sustain, and if anything, get a little bit stronger in terms of a stronger relationship between housing and ART uptake. But among states that are received at or above the median level of HOPWA funding per person, you see really an effect measure modification. You see that relationship attenuate between homelessness and ART. And so it's speaking to something that is happening in these states, and that HOPWA may be playing a role as part of that story about providing people housing support, and that part of that is attenuating that relationship and ideally doing better to deliver ART and to support ART use among people living with HIV, among gay and bisexual men living with HIV. And then now to sort of move on to an international dynamic. And so this whole time I've really focused obviously on the United States. And when we look at sort of the burden of HIV amongst gay and bisexual men across the US, it's somewhere about 15 to 18% of gay and bisexual men are estimated to be living with HIV. These are epidemiological studies, so a little bit different than the case diagnoses, but just an ongoing systematic review that we've had of any epidemiological studies. And I think, when people think of HIV, and particularly in other parts of the world, they'll say, well, the idea that HIV disproportionately affects gay and bisexual men is really a dynamic in Europe and the US, maybe Asia, but not so much in other places. But actually, when you look at the burden of HIV among gay men in the Caribbean, among gay men across sub-Saharan Africa, in South and Southeast Asia, you actually see a very similar burden. That's somewhere between 15 to 18% of gay men are living with HIV. Higher in the Caribbean, a little bit lower in West and Central Europe. But it's really that there's a lot of similarities. And I think part of that is because we have no data at all that says that there are any evidence in the diversity of sexual orientations and gender identity. There's no strong data that speak to that globally anyway. And there is obviously clear differences in terms of the nomenclature we use, in terms of the safety and prevalence of outward sexual and gender expression, obviously differences in social acceptance and the prevalence of both punitive and protective laws. Those things obviously vary. And when we look at things like this sort of HIV cascade, some of you may be familiar with the UNAIDS language of what was 90-90-90, it moved to 95-95-95. The idea that we want 95% of people who are living with HIV to be aware of their status and ultimately linked to treatment. Work that was led by a group at Imperial showed that amongst gay men across sub-Saharan Africa, it's something like 25, 10, and 8. That about 8% of gay men across sub-Saharan Africa who are living with HIV, aware of their status, are currently accessing and have achieved viral suppression. So incredibly far from where it's intended to be. But yet, when you work across the area, these modes of transmission studies, which a lot of countries use to sort of assess who's at risk and who should we focus on as part of a meaningful HIV response. You can see that when they look at the sort of percent annual infections that are related to the unmet needs of gay men, and historically it was very low. Either they would say it's 0 and they wouldn't even put out an estimate, or it would be very low. And here the highest one was Kenya with about 16%. But they would always sort of this message of like, well, that again, that's not part of our story. And in Senegal, historically, I think they said it was about 4%. Just based on sort of the way that they had done this work. And so engaging, there was a particular opening with the government of Senegal to see if they were open to doing this in a more meaningful way and to using better data to sort of empirically assess whether that's actually true. And we used a very traditional model led by a group also at Imperial and other UK universities, including Sheffield, to ask this empirically. So to look at, including in their model, people selling sex, female sex workers, but also data from cisgender gay men as well as transgender women, and then including that in their more sort of general model. And also not just asking it from a sort of a one-year time horizon, but over a longer time horizon. So what happens over a 10-year time horizon? And actually, when you do this and you ask this, what you can see here in blue is that it looks fundamentally different. That the unmet needs related to sex between men, all of a sudden is more like 40% of their epidemic. And the unmet needs, in fact, when you look at it over time, it's only increasing, that there seems to be a concentration, that they seem to be doing better for their sort of the overall folks. But yet, based on exclusion and based on prevalent stigma, actually the epidemics continue to concentrate. And it's probably more like 60% of the infections over a 10-year time horizon are related to the unmet needs of sex between men. And this wouldn't be that different if we were looking at data from Peru or maybe even more so, from the US and Canada. But that dynamic was really something that was important for them to understand. We also, because there was so much, I think, pushback at the time, we also did this in a different way, which was that we used phylogenetic data. So some folks may be aware that in the context of these large-scale surveys, a lot of the sequence data, whenever people living with HIV have their sequences completed, it's sent to this lab in the Los Alamos lab where they sort of like contain these sequences. And the vast majority of these sequences in Senegal were just sort of considered the general population. They never bothered to ask people and never created a safe space to ask people kind of, who they were and if they had any other dynamics. And actually, when we did this and we were able to sequence, amongst people living with HIV, we saw that the population attributable fraction was about the same, that about 50% of all these sequences historically that had been collected in Senegal were actually very closely clustered to the sequences that we could see among Senegalese gay men living with HIV. And so it really reinforced in the most objective way possible to the government. These aren't just, epidemiological models. In fact, if you had gone back and asked folks, you really have unmet needs amongst gay men living with HIV, and it's a critical part of your overall dynamic. And I think it's allowed them to sort of shift their, at least HIV response over the last number of years. But that is also happening in the context of, clear structural determinants. And so, we wanted to look at how structural determinants were affecting HIV risks among gay men across sub-Saharan Africa. And we had led a number of these surveys over the years, and others had led surveys over the years. So we had data from 10 countries across West and Central and Southern Africa, 23 study sites with over 8,000 gay men included, all recruited by respondent-driven sampling, biological HIV testing. And we categorized using the ILGA classification of either not criminalized, no legal protections, but no criminalization, versus criminalized with up to 8 years of imprisonment, and then severely criminalized in terms of 10 years to life in prison. And as we know, there's increasing threats of death penalties. I will also note that the actual situation has worsened over the last number of years. Some folks may or may not be aware, but it's actually, there's more laws being implemented in places that didn't have laws, and some wins, but mostly losses in this space. But when we make this case and when you show this, that gay men are disproportionately affected across sub-Saharan Africa. But in settings where gay men are criminalized, they're more than 2.5 times more likely than other gay men to be living with HIV. And in severe criminalization, they were more than 5 times more likely to be living with HIV, again, compared to other gay men, and just speaks to the power of criminalized dynamics. And again, these are adjusted for lots of individual level determinants. So we're really trying to isolate out as much as possible the sort of policy determinants. And that the same thing held true for HIV testing. So these are data for ever HIV testing. So our most basic intervention to guide people either into treatment or into PrEP or other services. We saw folks that were in criminalized settings, 12% less likely to have ever tested for HIV, and in severe criminalization, 40% less likely to have ever tested for HIV. Again, reinforcing how powerful those structural determinants are and how hard it is to overcome them, in the context of harsh criminalization. The second last data slide I will show, this is a recent review led by Sari Reisner and Aidan Scheim and others, published in PLOS One, but really speaks to the paucity of data internationally for transgender women. So what you can see here is the sort of the size of the circle is based on the numbers of studies, and the categories of those studies was color coded. And so what you can see is that, across much of the world and most countries, you have no data for transgender women. If you do, they're exclusively often HIV-related studies. with sort of few exceptions. And so it really speaks to this dynamic that even in 2023, and this hasn't changed much in 2024, we really have not improved our understanding of the needs of transgender women to the extent that we need to, I think, for better service delivery and better understanding of the HIV epidemic overall. One piece of good news that I think, this is work that AMFAR, Greg Millett, and others have been categorizing over the years, is that PEPFAR, which is the President's Emergency Plan for AIDS Relief, has been increasing its investment in what they consider key populations broadly. So that includes gay men, transgender women, people who use drugs, and people with self-sex of all genders, from about $178 million to about $276 million. And part of that increase has been amongst gay men and other MSM. Part of it has been amongst transgender women. But that dynamic that, I think many of us are concerned about this future, but over the last number of years, that the advocacy has resulted in really significant increases in the investment in these services. So just some thoughts to kind of close off. As somebody who spends a lot of time in different spaces, I really feel like the world is really far more similar than it is different. We actually do not have data of regional differences as to why people have consensual sex, and also of the diversity of sexual orientations and gender identities. And I think, as we move towards trying to do better internationally for HIV, we kind of have to overcome those preconceived notions. And we have to realize that who we are leaving behind is actually going to affect the response as a whole. And I think as we, and that similar to that, we have to move from stigma rhetoric, which we hear domestically and internationally, to really responses, to improving upon those as a way of improving upon that and ensuring we don't leave people behind. And so, again, I think some of those closing thoughts are that hopefully I've made the case, and I'm sure many of you have your own data, and hopefully were believers before, that the data supporting the role of structural determinants are powerful drivers, not just amongst all, but within communities. And so, yes, that we know that gay men and transgender women are disproportionately affected. We know that gay men of color are disproportionately affected, but that you can tease out the structural determinants that are driving those disparities within communities, and those are central to doing better for folks overall. I think, it's amazing that in this year, there remains this urgent need for structural interventions to ensure better access to social, economic, healthcare, and safety resources. And again, that is just going to be more powerful moving forward. And I think importantly, we're not starting from scratch. There are so many promising strategies and policies that are out there, and we need to build upon them. You'll hear from Dr. Gang about how to optimize implementation of them and develop strategies, but we have to do all of those things, and we have to do them in a really meaningful way moving forward. So indeed, Bob kind of introduced Chimes, which we're really excited about, but it's a collaboration between Johns Hopkins and Emory, with us being focused for folks who are interested in measuring stigma and responding to stigma. We're really keen to do things like specific aims reviews and help you publish papers and help you travel to places to present data, and happy to follow up with anybody who's interested in that moving forward. And we hope to build those collaborations with the HIV Center. So sort of a shameless plug, but a shameless plug to ideally provide services to you all. And then, of course, I want to thank, we've had over 90,000 unique AMOS participants since 2014, over 5,000 TWIST participants, a huge team within the Program for Implementation Equity Research, and as well at Emory, and then lots of support from the NIH in terms of NIMH and NINR and NIAID that we're thankful for. So with that, to open up discussion.